Guys, no, make 1 seat gap between you all so that there's some social distancing and you guys cannot copy from each other. We'll start out the quiz in next 2-3 minutes. I'll distribute a question paper to all of you. You have to write your name. There are 30 MCQs in the quiz, and each question will have a single correct answer. I hope you are carrying a pen with you. Tick the answer that you think is correct from the options A, B, C, D, and submit the paper. We'll evaluate it, and we'll probably, during the inauguration, we'll declare the winner, and the single winner will be declared, and they'll get a prize. Okay, any questions you have before we give you the question paper? And once again, please, no, do not sit side by side. Make a seat, gap. You are allowed to keep your mobile phones with you, but we expect your mobile phone to be off. Do not try to find out the questions from answers from Google. To our online audience, thank you for joining. We're starting out with a psychiatric quiz for the interns. And maybe in the next 15 minutes, we'll start the program.
Okay. Can you hear me on the, I'll just disconnect the phone. Can you hear me on the audio?
Dr. Sunita Kumar Das, Associate Professor and Organizing Chairperson of today's workshop. I'm Shivani Tripathi, here to welcome everyone who has honored us with their solicited presence and to ensure a smooth flow of the workshop. Today, we have gathered here for the National Webinar Cum Workshop titled as Therapy in Everyday Practice. First in line, we have interview skills in ethical clinical practice for medical practitioners presented by Dr. Sunita Simon, chaired by Professor Dr. K.K. Mishra sir and Dr. N.N. Raju sir, President of the National Body of the Indian Psychiatric Society, as the online moderator. It's an extreme pleasure for us to have you here with us at short notice. A briefing about Dr. N.N. Raju sir. He graduated from Andhra Medical College and he did his post-graduation from Central Institute of Psychiatry. After a short stint at CMC Vellore, he started his professional career as assistant professor at Government Medical Hospital for Mental Care, Visakhapatnam, and later retired as its superintendent. His contributions in development and progress of Maharshi Institute of Neuropsychological Disorders have been noteworthy. We have Professor Dr. Biswaranjan Mishra, AIMS, Bhubaneswar, as the subject expert who will be introducing the theme of the presentation. Dr. Tufanpati sir, HOD High-Tech Medical College and Hospital, Odisha, as the moderator. I request Dr. N.N. Raju sir to officiate the beginning of the scientific presentation. I request Professor Dr. B.R. Mishra to please come on stage. The other moderators would be joining online. So without further ado, I now hand over to the chairpersons to coordinate our first presentation.
Good afternoon to all of you. Respected organizers, respected Professor Das, Dr. Russell, my seniors, and dear colleagues and friends. I have been given the responsibility to introduce the topic of interviewing skills in regular clinical practice for medical professionals. This topic is not only important as a psychiatrist for us, but it is equally important for all the medical professionals. Now, in psychiatry, we are dealing with a subject where we don't have any instruments or any arms to explore into the patient. The only thing we are left is observing the patient and interviewing the patient, and a lot depends on how we are going to interview and what is going to be the analysis of our interview, how we analyze the symptom clusters, and how we reach a diagnosis before we start. So an essential component of interviewing is, first of all, that the interviewer should have patience. A lot of patient hearing is required. There are few variables which should be there in an interviewer, because the patient you are dealing with can be different. We can come across different set of patients. The presentation can be quite different. So the basic essential component of interviewing is an empathetic listening to the symptoms told by the patient. Another important element is what is called the reflective listening, where you make the patient feel that his problems have been addressed and are being understood properly. So a patient, empathetic listening, and reflective listening, these are few basic elements which should be there as a part of our routine clinical practice. So with this, I open up the topic and I request Professor Sunita to kindly take over the session and give her lecture on it.
Thank you. May I share my screen?
Just a second, I'd like to request Dr. K.K. Mishra, sir, who is also online, to kindly introduce ma'am before she starts her talk. Dr. Kiroz Mishra, sir.
Hello, good morning. Am I audible?
Yes, sir.
Hello?
Yes, sir, you're audible.
Am I audible? Good morning, everybody. And at the outset, I must thank all the organizers, starting from Russell to Professor Das, Sudeep, and all the faculty teams giving this opportunity to be the part of this nice program. And I have the nice responsibility of introducing Dr. Sunita, whom I know for last 20 years or 2 decades. And Sunita presently is a professor of St. John's Medical College, and she is in the professor and HOD of Ethics Committee of the institution. And I know Sunita for a lot of work she has done in the areas whether like the doctor-patient relationships, the boundary areas, boundary issues. She has a lot of areas. And already Dr. Biswa has introduced the topics. So without wasting much time, I request Sunita to start her presentation and for which actually everybody waiting. I welcome you all.
Thank you so much for that introduction. May I share my screen now? Am I visible and are my slides visible and I'm audible?
Yes, ma'am.
Yeah. Yes, yes.
Okay. So good afternoon. And before I start, I really must thank the organizers for giving me this opportunity to spend some time on this session with you. A special thanks to Dr. Russell and Jignasa for involving me. So what I thought I would do the next, discuss over the next 20-25 minutes is sensitize the audience, especially the students, to some of the ethical issues and challenges in our clinical interview with patients. And in St. John's over the last many years, we do orient our postgraduate students to the ethical issues at the start of their program in St. John's. Apologies for the spelling error there. And because we do realize when young doctors transition from interns to first-year postgraduates, it is useful to sensitize them on some of the issues so that I mean, I think it's well known in medicine, all of us have learned from mistakes, and that adds to our experience, but where we can avoid it, it's always useful. So we hope sensitizing young doctors would help them to avoid some of the mistakes we have done. And also to sensitize us to learning from our interactions with patients. And I think as Dr. Biswas rightly, when he introduced the topic, spoke about reflective learning with patients, it's also important for us to do that for ourselves. So I must say that some of what I talk, especially for the seniors in the audience, you might find that redundant, but as I said, I had prepared this with the idea of for young doctors, for juniors in the field, and as well as for those of us who need to sensitize or teach students about this topic. So I thought I'll talk a little bit on the background of the importance of interviewing in psychiatry and in fact in medicine, some relevant ethical principles, and some of the special situations and challenges which are important aspects in psychiatry, with a final take-home message. And one of the caveats is that when one does a session on interview skills, especially in medicine, the learning is very much by doing. And so again, what I will be discussing today will have to be taken in that context. And as we practice, as we talk to patients and experience working with patients, our skills get better, with that. So as a brief background, if you look at psychiatric interviewing versus interviewing in general medicine, of course, there are similarities and some salient differences. And one of the bottom line issues would be that the knowledge of how to do the interview and the techniques are very similar in terms of, introducing yourself, active listening, using your verbal, non-verbal skills. All that is very similar. And but probably one of the key differences would be that in psychiatry, the interview can be particularly therapeutic, and especially when you're talking to a distressed patient who's going through depression or experiencing suicidal ideas, talking about it itself can be therapeutic for the patient. And while I say we rely more on history than investigations for diagnosis, history, and mental state, increasingly our colleagues in all other specialties are also recognizing this importance, and including the NMC, because of the increasing emphasis they're putting in the AdCom sessions from the first year to the final year for students in the new CBME syllabus. One point to remind ourselves is that we interview patients in different settings. So we have to tailor our interview and our interactions according to that. In the ward, when the patient comes in for a detailed workup, yes, we cover all our aspects and everything in detail. Sometimes in the ward, we clarify things after a couple of days, or we review the patient, or we deal with an emergency and we may have to deal with that in a slightly different way. When we work, we deal with, especially in a general hospital, we work with referrals in emergency department or in other wards or following deliberate self-harm. And in the outpatient clinic, we deal with new patients or follow-up. And though many of us may refer patients for, say, formal CBT or DBT to our psychology colleagues, many of us may use aspects of therapy in our routine clinical interactions with patients. So it would be important to be alert to some of those issues. One point I always tell young students when they start out in medicine, in psychiatry, is that be open to getting different histories at different time points from, the informants. And when there are discrepancies in the history, don't push the patient into the corner. I think all of us have had the experience where when the junior doctor talks to the patient, they deny history of suicidal attempts. And when the senior doctor talks to the patient, they say, yes, we had we attempted suicide a year ago or something like that. And it is important not to push the patient to the corner saying that, but you never told me that when I asked you that last, earlier. Because sometimes patients need time to get comfortable and disclose history. And many times patients do that sequentially. And the first interview may not give you all the information you need. And especially if you're dealing with a hostile or an uncooperative patient, the first interview may only set the stage for rapport. Do doctors really need to discuss ethics? I think it is really fantastic that this session was set up, because increasingly we are aware, we do realize that awareness is important. At a maximum, from a professionalism viewpoint, being sensitive to ethical issues makes us better doctors. And at a minimum, we need to be aware of the legal issues to ensure that we don't get into difficulties in our clinical work. And if you look at the historical aspects, nothing much has really changed. I mean, one thing the Nazi era in the 40s, last century, taught us that doctors cannot be relied upon to be ethical at all times, though most doctors can be relied on to be ethical most of the time. And stigma in psychiatry has been a problem, and unfortunately continues to be so. And increasingly, we are aware of the issue of self-stigma, where society may, many people have changed their opinion about mental illness and may be quite open about psychiatry and interventions. But for many patients, their idea of stigma is still huge. So when in our interview, we need to be aware of that, where for some patients, it may take time for them to open up and to discuss these sensitive issues. The other problem in psychiatry is that, especially when you're dealing with major mental illness like psychosis, it affects the patient's thinking, and that adds a special vulnerability to psychiatric patients. Now, before we talk about history, there are some basic first things which may sound quite silly, really, but it is only when we don't do it at times, or we take it for granted and we get into some difficulties, we realize the importance of this. So for the seniors, I do apologies for this rather basic slide. The first thing is to be very clear as to who is the patient. Now, when you're sitting in the outpatient clinic, or you have a patient surrounded by 4 or 5 family members, it is quite important to be clear as to who is the patient. And always introduce yourself, even if you have a name badge or you have a board outside your room, it is important to introduce yourself. Ensure safety and privacy, and privacy as much as is possible safely. I think COVID has changed our practice very much. And in the outpatient clinic, earlier I used to always close the door to my chamber. After COVID, I ensure it is open for cross ventilation. And that is something I do tell my patients that I'm sorry, I can't close the door as part of the COVID protocol. And that is something we should be okay about. It is important to see the patient and the family member or the attender together briefly, and then separately if you feel it's appropriate and if you feel it is safe to do so. Especially when you're seeing a patient for the first time in the emergency clinic, in the emergency department, or in the outpatient clinic, it is very, very important to trust your own instinct and don't override it if you feel uncomfortable. And this is something that, we should be absolutely comfortable to listen to ourselves. Again, it is important to clarify why a patient has been referred to you. And if they are uncooperative, like catatonic or delirious, or if it's likely to be an involuntary admission, we need to be aware of that situation. And even in involuntary admissions, we need to explain truthfully to the patient what will happen. That is one important thing, and I'm sure many of you would have had this experience, that the family members, for whatever good intent on their from their viewpoint, it is important not to allow them to pull you into a deception, and explain that to the family. Why I mean that is, sometimes family members tell the patient, we've come to hospital because the grandmother is admitted, and then they bring them to the psychiatry ward and they want you to do an involuntary admission. Of course, you may end up doing an involuntary admission, but it is important not to deceive the patient into that. And I always explain to the family that, this is the first step in my relationship with the patient. And if it is based on this, then I'm unlikely to be able to build the foundation of a good doctor-patient relationship later. Of course, common sense is important, and sometimes we may have to explain to the patient all these things after putting issues, the logistics in place. For example, if you're seeing a patient in the outpatient clinic and the patient is likely to be violent but needing admission, you may have to call security or adequate staff, and if you need to sedate the patient, you may need to do all that, but it is still possible, and the right thing to do is to explain what you're doing to the patient before you do that. The other point which I want to spend a few minutes on is this issue about violence against health personnel and why we need to talk about it as part of ethics. As Dr. Mishra said, I've been talking about doctor-patient relationship to our students over the last, at least 20, 25 years in St. John's. And what I have definitely seen a change in the last 5 to 10 years is that especially young doctors are understandably worried about violence because it gets a lot of press, and attention. And I think it is important to be aware of that. And because the doctor is a very important part of the doctor-patient relationship. So the doctor should not feel unsafe. And if the doctor does feel unsafe, we need to make sure systems are in place to make them, comfortable. So safety issues are very, very important. And there are certain settings which are a little more risky. I mean, definitely I often feel the psychiatry ward is one of the safest, actually. It's the emergency department, which would be, potentially unsafe. And when you're dealing with intoxicated or agitated, acutely manic or delirious patients, you need to take steps to protect yourself. And especially if you're tired, if you're the duty doctor being sleep deprived, and if you're trying to handle a situation with inadequate information. So I always would say that if 5 people have brought in a patient to the outpatient clinic, let them all be there when you start the interview. And then, because if you're not sure how safe it is for you to be alone or with less people with the patient. Be alert to warning signals. I mean, I'm not going to spend too much time on that other than 2 things. One is when the patient starts pacing around or people stand up and or when they raise their voice, those are early, warning signals. And it is absolutely fine to think of your safety. I mean, sometimes young doctors feel guilty about that, but there's absolutely no reason to feel guilty about it. And if advocacy needs to be done to take steps, and if management needs to be sensitized to that, I think this is a very powerful image which showed us that, when young doctors are feeling unsafe, we have to, respond to that. And now moving on to some of the basic principles of medical ethics, which I'm sure all of you are aware of, but I'll just spend a minute on that. Autonomy, as in the patient has a right to decide for themselves, beneficence in terms of doctors doing good for the patients, non-maleficence as do no harm, often considered as the most important medical principle. If you can't do other things, at least remember this point. We need to remind ourselves about this. And justice in terms of being fair to patients and to ensure that biases don't come into play. And one note to say that in the time of a pandemic, justice, it may be understandable for justice to take a hit. For example, it may not be first come, first served who gets the ICU bed, but the person who may have the greater need. And that is acceptable when you're dealing with the pandemic and ethics in that situation. I thought I would spend a few minutes on some of the issues which are relevant to psychiatry in terms of, and I think informed consent is one of the most important things. And we know while autonomy is very, very important, in India, the role of culture is still very, the role of the family's role is very, very important and often a source of strength and something very positive for the patient. But ultimately, we need to remind ourselves that it is still the patient's choice of who they would want to involve in the family, or if they don't want to involve someone in the family. And the Mental Health Act has given the option of the patient even nominating someone outside the family as someone to, if their capacity to consent is affected, it can be a legal guardian or nominated representative who can be involved for choices. And we cannot assume that capacity is impaired in psychotic patients, and the context is important. And I'm not going to spend time about research and things like that, but when informed consent is not possible, assent is important. And as I mentioned briefly earlier, if involuntary admission is absolutely necessary, then obviously the patient is not assenting to it. Try and do it with as much respect for the patient that is possible, that is obvious, so that future rapport is not affected. The reason I say that is that I know we all do respect our patients, but it is important to make sure that it comes across like that to a patient, especially in an emergency situation, and if they're being sedated and things like that. You don't want it to be an uncomfortable memory in the patient's mind later. The other important aspect is about confidentiality and disclosure. And it is very important to set the stage with patients, especially if you're dealing with young people in the outpatient clinic, to reiterate that you would keep things confidential, but there are certain limits to that, that is the safety of the patient or safety of others. And a common problem area is when a young person discloses the risk of self-harm, and they don't want their, say, their parents to be involved. And it is very important to make it clear that you have to disclose about the self-harm risk to the parent. But of course, you may choose not to disclose a stressor. So often if it is a relationship issue, I don't disclose that to the parents, but I would disclose the fact that yes, the young person is at a risk of self-harm, because the family may need to take steps to keep them safe. Again, a similar issue with substance use, where sometimes parents bring the young person and they want to know the history about substance use. And it is important to tell them clearly that unless it is very relevant, like a substance-induced psychosis, you should not break confidentiality, but you would definitely encourage the young person to communicate this to the parents. And in my own experience, I have found that parents clearly know what is going on actually. That it is one of those open secrets. They've actually checked the young person's room and they've seen the substances, but they've sometimes not confronted the young person. So sometimes we need to facilitate that. And including high-risk sexual behavior, it is if there is an immediate risk of some sexually transmitted disease, then again, this is a situation where I would often encourage the patient to involve their partners rather than me have to do it, because that creates a lot of practical and logistic problems. But if you feel clearly that the patient is not going to tell their partner and there's a high risk, then you have to follow the law and break confidentiality. It is important to explain the limits of confidentiality. If somebody is referred for an opinion, or for example, a company requires a medical certificate, or if there is an insurance claim, then you need to ensure that you cannot, need to tell the young person that you cannot keep things confidential and document accordingly. One of the things I have learned over time is that when I break confidentiality and disclosure is going to happen, it does make things difficult for everyone and uncomfortable, including for the treating doctors. So it should be done as sensitively as possible. And as far as possible, I always try and involve the patient before breaking confidentiality. For example, I've sometimes, after discussing with the patient, I've used their phone on speakerphone and informed the family so that they know exactly what I've talked about. And so that is, I found a safe way to do this. Sometimes we have to involve others if there is a risk of harm, and the police have to be informed. Again, a very, very difficult situation. And here again, I have found it best to inform the patient. And there have been times when if I've had to give a letter to the police, I've copied the patient onto the letter, and I've read the letter to the patient so that they know exactly what is happening. And the other thing is, if unsure what to do and that happens, and how to do it, because often we know what to do, but it's the how to do it that we find it difficult. Discuss it with colleagues. And especially when you're going to, if it's an issue of breaking confidentiality or something with potential legal implications, it is important to get legal advice, beforehand. The other aspect which is relevant to psychiatry is the issue of boundaries. I'm not going to spend too much time on it, but as you know, it is a set of rules that establishes a professional relationship, and very important in psychiatry because we do need to ask very personal things. We do need to invade their mind, so to speak, so we do need to ask personal history, sexual history, about habits. So it is important to do it sensitively and to maintain our professionalism. And there is a need for boundaries, and what we call non-sexual and sexual boundary. Sometimes there may be crossings which may be acceptable and violations which are absolutely not. And to be aware of certain risk patients, especially if we're dealing with patients with borderline personality or persons who've been sexually abused in the past, a comfort touch on our part where we may not have meant anything sexual may be taken as something else by the patient. So we need to be aware of that. And also risks in ourselves. And if we are going through a marital disharmony or things like that, we may be a little more vulnerable to some of the boundary issues. And one point which I always reiterate is that, in fact, when I discuss boundaries with my students, I have a slide with all the mistakes I have made in my career. And I think we all learn from that. And it is important never to cover up. And if we make a mistake, to discuss with a colleague. So a boundary crossing need not become a boundary violation. And the bottom line is to remember that it's a professional relationship, not a friendship. But it does not mean that the relationship should be cold and impersonal. We should have a warm and empathetic manner. And a manner can be friendly, but it doesn't mean that we are friends with the patients. And the reason for that is the importance about non-sexual boundary violations, because people may think, what is a problem taking a gift? Is that not all non-sexual boundary violations lead to sexual boundary violations? But if you look at the converse, nearly all sexual boundary violations have started as non-sexual boundary violations. And for those of you who'd like to know a little more about this, there's an 18-minute film freely available online. It's with some text, so that if you just Google boundaries film in St. John's, you'll come to that page. And if you read through that page, and the second page, there is a link to the film. And this might be something that is quite useful for young doctors to go through. And a last few points, I think I'd like to spend a minute on the importance in psychiatry about looking after yourself from all physical, mental, emotional, and spiritual viewpoint. And the importance of that in general terms, being competent as a psychiatrist or as a doctor is one of your most important ethical requirements. And as I said earlier, the doctor is a very important part of the doctor-patient relationship, and looking after yourself emotionally and physically is important. Another very, very important part, when you look at interview skills in psychiatry, skills in medicine is very much as part of experiential learning. So learning to reflect on what you have done, and not just in what you've done and how you feel about the interaction, and self-assessment. These are very, very important tools. Again, this is something the MCI, the NMC has now recognized. And in the ADCOM models, they periodically talk about reflection. And I think it is something that is, I think a lot of psychiatrists do it naturally. They, as a group, they tend to be very self-reflective. And it is a very important skill to learn. And you may be aware of this, is a Delphi oracle several thousand years ago in Greece. One of the most important things, the first rule was really to know yourself. And in medicine, in psychiatry, in our interview, it is very important because self-awareness helps us to neutralize our biases and protects patients. A simple example would be that suppose we had a difficult family environment growing up in terms of, say, somebody we knew and loved was involved in domestic violence or substance use. if we're dealing with a male patient with alcohol dependence, some of our biases may come in that interaction. So you need to be very aware of that so that you don't do that and cause a problem in your interaction. Very rarely, if you are in a situation where you feel very uncomfortable with a particular patient, and for whatever reason, it is absolutely fine to hand over their care. But prepare the patient for the handover and explain why you're going to do that, but use your judgment. If it is something to do with you personally and you feel you don't want to share that with the patient, obviously, you need not discuss about your personal feelings and thoughts when you hand over the patient to somebody else. And some final points about interviews. It is very important to give patient your attention. Active listening is very important. In this age of mobile phones, it can be very difficult. If you're on call, and sometimes that has happened, it is important to tell your patient that, look, I'm on call, I may get interruptions. Sometimes in the outpatient clinic, for example, if some of my colleagues are on leave, I may tell the patient that, look, I'm the senior doctor available today, so many of my juniors may come in and interrupt their session. I think that is a good thing to prepare patients so they don't get upset about it. It's always good to summarize the plan at the end and ask if any questions, because we may have got something wrong. The patient may needs to be given an opportunity to clarify questions. And I put this point because I think that is something it's important in any relationship. Sometimes things go wrong. I mean, a long waiting time, and sometimes it may be things which are not necessarily in your control. But if something has gone wrong, do apologize to the patient, and that really helps in the doctor-patient relationship. Also important to handle emotions in patients, in ourselves, and silences. I mean, sometimes, especially when we are new to psychiatry, we have a tendency to keep talking, filling up silences. But allowing silences is absolutely fine in a good interview. Another aspect is handling transitions. And what I mean by that is you may, in an outpatient clinic, we may not have the luxury of too much time with the patient. And say a patient has talked about, say, a family history or self-harm, and they're tearful. You may want, after a few minutes, to move on to asking about something else. So if you're not sensitive, it can come across as being not sensitive to the patient. So you may want to say that, I know it is upsetting for you to talk about this, and we'll come back to this, but is it okay if I ask you some other questions? That way you transit to another topic, and the patient, and you can always come back to this issue later. There are always some special challenges, and one of the issues in India is that we know it is not just one culture, and we need to be sensitive to patients who may have different backgrounds, and that is something we need to be alert to. And COVID, this is a picture of my senior resident Ishan in 2 years ago, when at the start of the COVID wave and the PPEs, and he was somebody who was amazing with all this, the PPE. He managed an excellent rapport with the patients he saw. So those are challenges where, in the COVID era, as we are so used to our non-verbal cues, this can be particularly a challenge. And if I would end with saying that, if we have a doubt as to how to proceed, or if something goes wrong in the interview, when in doubt, ask your colleagues how to handle. And it is important to reflect regularly on our work. And in fact, I remember one person said, an experienced person is not somebody who doesn't have things go wrong in the interview. An experienced person is someone who keeps their calm when things go wrong in the interview. And I think that is something to remind ourselves about. So I'll end there. And if there are any questions or comments or contributions, I'd be happy to take that. Thank you.
Raju sir, you can take over. Vishwaranjan can take over. Question answer if anything is there.
Yeah, I'm there. No, Ravan, no issues.
Thank you, madam.
Vishwaranjan आगे कोडने से.
Now I request the floor to contribute or to have questions or comments. We will prompt and give responses quickly.
Dr. Sunita.
Offline.
Yes, sir.
I'm an old man. Nobody should mind my touch convention. If I'm going to speak for 25 minutes, speak for 25 minutes. Second point I always have, many times patients don't want to come to psychiatry. They're afraid. They're going to Pagal. How do you handle that? You got to refer this patient.
I'm sorry, was there a question? I couldn't hear properly.
So, ma'am, actually, sir wanted to ask, many patients come to other disciplines with basically prominently psychological issues. But when they are referred to psychiatry department, they are panicked about it. So, in such scenario, even if there is a problem, the doctor identifies, but is able to refer properly. So, in this kind of situation, what should be like the approach of the doctor, of the particular doctor towards the particular patient? How he can be convinced and referred properly?
Okay, if I've understood you right, the question is that sometimes somebody is referred with psychological issues, but the patient is panicky about it, or the referring doctor or family may feel a little uncomfortable about the psychiatry referral. Is that the gist of what you're asking, how to handle that?
So I'm saying they resent to come.
Yeah, they don't want to come.
Okay.
So in that case, how to convince them and how to, what should be our approach?
Okay, fine. I think that's a very good question. And sometimes, we often are in that problem. We face that. And over the last few years in St. John's, what I have discovered a couple of ways in which the situation presents itself. Sometimes we've had a request that please see this patient, but don't say that you're a psychiatrist. And the other, it stems from their anxiety and stigma. So I often spend more time with whoever has made that referral rather before I see the patient, because I tell them that there's no way I can see the patient and not say I'm a psychiatrist. So in that situation, sometimes it is the anxiety of the treating doctor, the referring doctor. Sometimes it's the anxiety of the family members. So in that case, I first talk to the family members, and then once they understand the context, and sometimes they're reassured after they see psychiatry that, sometimes the biggest worry is that will the patient get more upset after talking to psychiatry? So what I tell them is, patient is already upset. You have already, your own antenna are up and you're thinking of getting a psychiatry opinion. There is no way I can talk to the patient without telling them that I'm a psychiatrist, because trust is a very important part of our relationship. At some point, they're going to find out, and how will I proceed? So I often find that if I at least have one session with the family beforehand, that is a way to neutralize their anxiety. So would that answer your question?
And just adding to that, I would like to share experiences from our center, particularly two departments. I take the example of gastroenterology and pulmonology. There are two consultants. I like the way they refer. The way they refer, the patient is reluctant. They listen to the symptoms, and after that, they tell that there is a problem with you. We are understanding there is a problem, either a GI problem or a respiratory issue, whatever is there. There is a problem with you, but there is some additional thing which might be beneficial to you if you go for counseling, if you opting for counseling services. It's better you go and opt for counseling services that will have an added benefit. With this, with these kind of small remarks, I have seen that it works well, and we get a lot of referrals from these two disciplines particularly. So it's how you are being able to convince the patient that's most important.
I think that's fine, and I think that's a good way to handle that. And certainly, one way to deal with reluctant patients is to tell them, and this is something my physician colleagues have done successfully. They tell them that I'd refer you to psychiatry, and you see the doctor and come back and tell me what happens. So that way, patients don't feel abandoned, especially if they're having, multiple physical complaints and you're thinking it's in the somatization spectrum. They don't want to feel abandoned to, like I'm washing my hands off, you go to psychiatry. So if when they phrase it in that way, the patients are quite happy to come and see us and go back and see the doctor. So that's another thing that helps. And also we need to be open to the fact that sometimes, especially, alcohol dependent patients may be quite reluctant to come for counseling. And so you can even phrase it that, you see what the doctor has to say and then come back. Because some of our patients are so fearful that we'll jump on them and admit them involuntarily for de-addiction that, because they've heard some horror stories about that. So I think that's also one way to handle it. And another thing is to ask them directly, if you don't want to see the psychiatrist, why is it that you don't want? And if they say no, leave it at that. And, the next time they come to see you, you can always, try and help them to go to psychiatry later. I noticed there's a question in the chat box. Should I take that?
Yes, you do that.
Okay, so the chat box, there's a question. What if a client had a bad experience about his treatment to an ailment in the past, and it affects the present and they remain uncooperative? What's to be done? I think, again, a very good question. And one thing is, I think as part of medical ethics, we would not want to go in if the patient is blaming the earlier doctor or the earlier treatment. We would not want to go into that, but we would definitely allow the patient to, if they feel that they've had a bad experience, it's important to listen to that and not downplay it, because otherwise the patient may feel that, all the doctors are ganging up on them. And to say that, we need to move ahead and how can we help? If they are uncooperative, for example, if they don't want certain medication because they feel that's caused certain side effects, I have sometimes found that it's important to allow them to express why they don't want to, why they're being uncooperative, and allow ourselves not to, keep a watch on ourselves that we don't get irritated, because sometimes that happens, a perfectly good treatment. And just a brief example to tell you that we had somebody some time ago who was a very good candidate for clozapine, and the patient agreed, but the mother kept saying no. And it was really quite upsetting for us, because we felt that, a good opportunity to give clozapine was being lost, and the patient was, losing time on this. But later, when we admitted the patient, the mother then disclosed that another sibling had been treated with clozapine and committed suicide within 4 days of clozapine. So the mother wrongly attributed that suicide attempt to clozapine. So that is why she was so uncooperative about it. So patients usually have a story behind that. So listening to that and addressing it could help.
Yeah. So any other questions from the floor?
There's another question on the chat box. Should I take that? About covert medication. Shall I take
just
that?
finish up, madam. You can just finish up.
We are short of time. So
This is
I'd just like to request Professor N. Raju, President of IPS, and Professor Tokanpati, the chairperson today. They're online, and I would request them to give their valuable words.
Raju sir, आपका concluding remark.
Professor N. Raju, sir.
Yeah, I'm there. I think there. Have you finished?
Yes, Sunita finished
Dr.
the
Sunita?
question. Yes,
I think there is still she has to answer a question. I'm not very sure about that.
I put it on the chat box because of lack of time about covert medication.
No problem.
So
I think basically that saves my time. If you take that time, I can talk for lesser period of time. That is my selfish idea. Anyway, thank you for organizing this webinar by Indian Psychiatric Society Odisha Branch. I congratulate, I think, the first program of the President, Dr. Pranab Mahapatra, and perhaps my first program also as President of Indian Psychiatric Society. So I really thank Odisha Branch for giving me that common function of the President. I think somebody was asking me what is the functions and responsibilities and of the President of Indian Psychiatric Society. I was jokingly saying, I think going around and inaugurating various conferences, functions, and CMEs. So I think the journey starts now, and I'm happy that. But anyway, jokes apart, I think I see 130 people logging in. And also, I'm happy that the program has started with Dr. Sunita, whom I really appreciate her perseveration of working on ethical issues. And once again, in fact, I was happy that the program was getting a bit delayed because I could listen to her more and more. And I'm really, once again, thank her for I think bringing all these issues which are least discussed. That is the most important aspect of it, because the boundaries, the ethical issues, especially during our clinical practice and also our interviewing skills. Most of the times, I think we take things for granted and then run into trouble. So I think perhaps this is where we can learn a lot of things. And I appreciate the Odisha branch for organizing the I think combining ethical issues, the guidelines and the therapeutic issues and interview skills, I think all together today. And I think this is something I would say that the innovative way of thinking of organizing such a seminar. And I congratulate them, I appreciate them, and I also wish this program a very good success, and I think I would be happy to listen to the various speakers which you have be brought in. And again, also appreciate that I think the Professor and HOD of Kalinga Institute of has a magnanimity of making the associate professor the organizing chairman and he himself being the organizing secretary. That is also an innovative, and also I really appreciate the brotherly relation they have, and I'm happy about that, and I'm sure all of us learn something out of this. And once again, thank every one of you for making me part of this, and once again, wish this program a grand success. And I see our friends on screen. Welcome you all. Please do enjoy the program today and also learn few things. Thank you so much. Once again, wish this program a very success. Thank you.
Now, may I request Professor Tokanpati to tell a few words.
Thank you. I am very much sorry. I was supposed to moderate this meeting, but I am unaware. And there are a lot of traffic jams which was beyond my control. I take this opportunity to compliment IPS President Dr. Raju, my dear friend, for being here with us, and Dr. Simon for a lively presentation which I've heard from the beginning till now. And Bishu has proceeded for me. And Dr. Simon has also taken up the questions direct from the chat box. Thank you, madam. I thank Dr. J.P. Raban. I shall be reaching within 2 minutes, I hope. And those who are physically present, I shall be meeting. And I thank everyone who is virtually over here for their kind presence and participation in our first program of IPS Odisha State Branch this year. And our chairman of the CME subcommittee, Dr. Devadatta Mahapatra, Professor H.O.D. Games, Dr. J.P. Russell Raban, President of IPS Odisha State Branch, Dr. Pranab Mahapatra. I thank everyone, and it was a learning experience with Dr. Simon. Though I was scheduled to attend, I am very much sorry. I stay in a different town. I was a bit jammed up on the way. But now I am in Bhubaneswar, shall be reaching very shortly over there. Thank you, everybody.
With this, we come to the end of the first presentation, and I thank you all for a very patient listening and a very interactive session. Thank you.
Thank you, sir. Thank you, Dr. Sunita ma'am, for your clear and quite detailed presentation. The nuances of ethics and communication skills were highlighted, which would be definitely helpful for our audience. This clarity speaks of your tremendous work on the ground level as well. We are honored to have you, ma'am. We would love to learn a lot more from you as requested by the organizing committee. I would now like to request Professor Dr. K.K. Mishra, sir, and Professor Dr. N.N. Raju, sir, to felicitate Dr. Sunita ma'am on behalf of KIMS and IPS OSB. And symbolically, I request Dr. V.R. Mishra, sir, to felicitate Dr. Sunita ma'am, and Dr. Jigyasa would be receiving the felicitation on her behalf. Everyone kindly give a big round of applause. Dr. Sunita ma'am.
Thank you so much. Thank you.
Thank you very much.
I request Dr. S.C. Das, sir, Professor Emeritus, for felicitating Dr. V.R. Mishra, sir, Chairperson offline, and Dr. K.K. Mishra, sir, online, and Dr. Udit Panda will be receiving the felicitation on his behalf. A big round of applause for both of them.
Thank you very much, the organizer. Thank you very much.